People are going to die in the near term because they walk into a hospital and there's no bed with a ventilator.
The way I look at a ventilator is a lung replacement. What if you did not have lungs? Or what if you could not breathe on your own? This gives us the ability to keep someone alive. What this virus does is think of a sponge. If a dry sponge is your lung and a wet sponge is the infected lung, what we call ARDS, where the lungs become like that wet sponge and it cannot absorb any more air. And now at that stage, you have to let the person recover on their own pretty much.
We're not at the apex, so we're still in the stage where we have the luxury, if you will, of gathering as much as we can.
Good morning, this is Dr. Umesh Kidwani, Director of the Cardiac ICU. This is normally a cardiac unit, and I want to show you how we've changed this unit to take care of our COVID patients. You can see how hard they work in keeping the area spick and span.
Here we have Dr. Matt Levin. Tell us a little bit about your split ventilator.
Sure. So we're taking what we've seen many people do online and adding what we think is the most important element, which is valves to control the flow and let you titrate what's delivered to the patient, and one-way valves to prevent backflow. So we've been testing it in our anesthesia simulation lab on 2 high-fidelity human patient simulators, both connected to a single ventilator. It works extremely well.
Our hearts bleed when we are in these situations where what you're seeing in New York already, when you see a physician who's unable to help a load of patients, and where they know that if this patient particularly got on a vent, they have a reasonable chance of recovery. It's a desperate measure for a desperate situation.
People are going to die in the near term because they walk into a hospital and there's no bed with a ventilator. I'm not going to let people die because we didn't redistribute ventilators.
Previously, the ethical dilemmas were mostly on the patient side and the patient's family side, but very rarely on the side of our capacity, our infrastructure, our ability to provide care. Our hospital, thank God, we are in Maryland right now. We are very well prepared. We are not seeing those kind of numbers. We are nowhere near those kind of decisions. So I want to make it very clear that this is not a reality that I have to face today, but I see what is happening in New York. I see what has happened in Italy. I see what has happened in China. So when I look at all those countries and their experience, that's where my agony comes from.
A very eventful day. We extubated a couple of patients and they seemed to do okay. One patient expired. It's very hard to lose a patient that you've been fighting for. And we had 3 heart-rending discussions with patients' families.
New York is in crisis. Help New York. And then pick up, decamp, and then go to the next place as this rolls across the country.